Part 1, The Basic Principles. Chapter 1, Metabolic Response to Injury. Introduction. As surgeons, we are extremely linked with tissue injury and its effects, both from the damage which operating inevitably causes. From the treatment of accidental traumatic injuries, the body responds to significant local tissue injury, whether surgical or accidental, with a series of systemic changes which affect the functions of vital organs. The surgical stress response is brought about by several pathways involving hormones, inflammation related cytokines, and neural circuits. It leads to alterations in body metabolism, wound healing, and immunity, and in the function of specific organs. These changes are known collectively as metabolic response to injury. While these responses are designed to limit damage and begin repair processes, not all the effects are beneficial by any means. They can lead to complications such as sepsis, which can then amplify and prolong the abnormal processes and lead to or prolong multiple organ dysfunction syndrome MODS. Given that these metabolic effects of injury can have a significant impact on recovery, survival from many types of surgery and surgical illness, surgeons require an understanding of them in order to care optimally for their patients. Successful management of metabolic response improves outcome and forms the basis of modern perioperative care after major surgery, as well as the treatment of severely injured and septic patients. This chapter will look primarily at the metabolic response to injury, while shock, fluid balance, sepsis, nutrition are covered in depth in chapter 2 and 25. Homeostasis. Homeostasis is the concept of maintaining a constant internal environment that allows cellular process to function optimally. Many aspects of surgery, trauma, injury affect homeostasis and can lead to organ dysfunction. Traditionally, the metabolic response to injury is divided into an initial period of catabolism, which may include a period of shock followed by an anabolic phase of repair and tissue healing. The catabolic phase begins at the time of injury and is characterized by hypovolemia, decreased basal metabolic rate, reduced cardiac output, hypothermia, and lactic acidosis. The main physiological role of this phase is to conserve both circulatory volume and energy stores and thus maximize survival chances for future recovery. A series of neurohormonal responses accompany these effects and trigger a systemic inflammatory response syndrome, where patient's body stores are mobilized for recovery and repair. The catabolic effects include muscle breakdown, weight loss, hyperglycemia, which themselves increase the risk of complications, especially sepsis. As the catabolic phase subsides, an anabolic rebuilding phase develops, which may last for weeks if extensive recovery and repair are required following serious injuries. Modern surgical care. The role of surgical critical care including resuscitation and organ support must be to work alongside with metabolic effects of injury, while patient is restored to a situation from which homeostatic mechanisms can achieve a return to normality. The systemic effects of injury still impacts heavily on survival and complications through the loss of muscle mass, sepsis, and MODS. In fact, modern treatment of major trauma can now be so successful that great majority of hospital deaths in developed countries occur after some days as a result of complex physiological process rather than as a direct and rapid consequence of organ damage or blood loss, although it is the initial injury and blood loss that sets the scene for later systemic effects. Parallel with the catabolic effects introduced above, inflammatory type processes cause immune suppression. While this inflammation is often initially sterile, the nature of the surgery and injury predispose to infection and sepsis. Impaired immunity as a part of metabolic response compounds the risk and explain why sepsis and MODS or failure is a key part of perioperative care and a leading mode of death among our patients. Even in modern trauma systems, MODS carries a mortality of around 25%. A consequence of modern understanding of metabolic response to injury, elective surgical practice now seeks to actively reduce the need of homeostatic response by minimizing the primary insult via minimal access surgery and by stress-free perioperative care or enhanced recovery after surgery, that is ERAS. This chapter will review the mediators of the stress response, the physiological and biological pathway changes alongside with surgical injury and the changes in body compensation that occur following surgical injury. Emphasis is placed on on why knowledge of these events is important to understand and rationale the modern stress-free perioperative and critical care. Summary box 1.1 basic concepts that we have gained is that homeostasis is the foundation. Homeostasis is the foundation of normal physiology. Stress-free perioperative care helps to preserve homeostasis following elective surgery. Resuscitation, surgical intervention, and critical care can return the severely injured patient to a situation in which homeostasis becomes possible once again. The metabolic response to surgery influences these processes profoundly, particularly through catabolic effects, MODS, and impaired immunity. Now, in this figure 1.1, hypermetabolism and increased nitrogen excretion are closely related to the magnitude of initial injury and show a graded response. Here, in this axis is the resting metabolic rate, and this axis are the days. Minor trauma, major trauma, starvation. You can see the difference in the resting metabolic rate in major and minor trauma. And in this axis, the nitrogen excretion, minor trauma and major trauma. This is the difference. The magnitude of injury response. It is important to recognize that in general or population terms, the metabolic response to injury is graded. More the severe the injury, the greater the response. This concept applies not only to physiological and metabolic changes but also to immunological changes and other sequelae. Thus, following major elective surgery, there may be a transient and modest rise in temperature, heart rate, respiratory rate, and energy expenditure, peripheral white cell count. Following major trauma in emergency surgeries, sepsis, burns, and these changes are accentuated, resulting in SIRS and with hypermetabolism, marked catabolism, shock, and even MODS. However, genetic variability also plays a key role in determining the intensity of the inflammatory response, with some individual patients responding much more dramatically than others to apparently similar conditions. Now, the mediators of metabolic response to injury. The tissue damage and inflammation. Tissue injury is sensed in several ways. Tissue damages causes the release of cellular and other molecular fragments such as damage associated molecular patterns. DAMs, damage associated molecular patterns, or alarmins. The DAMs are sensed by pattern recognition receptors (PRRs), such as toll-like receptors, node-like receptors, or nucleotide binding leucine-rich repeat receptors on the cells of innate immunity system, which includes macrophages, neutrophils, and dendrites. These cells are attracted and activated, triggering the formation of complex intracellular proteins such as inflammasomes. This results in activation of caspases. These are the enzymes that in turn activate the key inflammatory cytokines, including interleukin 1, interleukin 6, and many others. PRR's activation also leads to the release of tumor necrosis factor alpha, interferons, cytokines, and other mediators. Thus begins a sterile systemic inflammatory cascade that leads to local local inflammation. When sufficiently severe to a clinically detectable SIRS, once activated by DAMs, inflammasomes also contribute to cell death, tissue damage, and immune suppression. DAMs can activate inflammasomes formation in endothelial cells and platelets, resulting in leaky capillaries, coagulopathy, and these changes that can result in production of more DAMs owing to local ischemia from microcirculatory effects. Local inflammations begin from microcirculatory effects. Local inflammation begins the process of tissue repair, but SIRS, when uncontrolled or prolonged, becomes a risk factor for acute kidney injury, acute lung injury, coagulopathy, and hence for MODS and organ failure. Within the injured brain, secondary brain injury can occur. DAMs thought to be important in tissue trauma include heat shock protein, high mobility group B1, S100 proteins, and fragments of nucleic acids. Commonly, DAMs are active several different receptors and pathways. This crossovers or redundancy, as it is termed, is a characteristic of inflammation and has been one of the barriers to a developing effective therapeutic blockade of these mechanisms. Furthermore, DAMs can be self-perpetuated during this complication course of surgical critical illness, amplifying and prolonging the inflammatory process and related organ dysfunction. Triggers to further release of DAMs include sepsis, hemorrhage, massive transfusion, acidosis, surgery, crush syndrome, and ischemic perfusion. Thus, the secondary insult of delayed or ineffective treatment of complications such as ongoing bleeding, ischemia, and sepsis will tend to maintain and amplify the inflammatory process and its resulting immune dysfunction. This can lead to a prolonged and self-perpetuating process. In Table 1.1, some secondary triggers of metabolic response to injury. Secondary triggers of inflammatory pathway in trauma and surgery: sepsis, hemorrhage, massive transfusion, acidosis, surgery, crush injury, ischemic perfusion. These events can amplify and prolong the catabolic phase, leading to organ failure and immune dysfunction.